Assalamualaikum and good morning. Sorry for the past few minutes. Actually, we not realized that we have problem with the audio system, so we need repeat back the lecture. I want to introduce today our prominent speaker, Mr. Rafizi is our neurosurgeon. Will talk on carotid endarterectomy and carotid stenting when to refer. This is very important in the light of stroke prevention, as the stroke intervention neuroradiologist, I always emphasize on healthy lifestyle, taking care of your diet, good sleep, and control your anger and also stress. So without delay, I would like to give back this morning space for Dr. Rafizi to talk about carotid endarterectomy and carotid stenting when to refer. Please.
Thank you very much, Prof. Khairul. I think due to technical error, we missed the introduction earlier, which was quite okay, but now we have to rush a bit. Anyway, today I'm going to talk about the carotid endarterectomy and carotid artery stenting. So we got probably less than 30 minutes now. Just my disclosure. Okay, outline of the talk, I just want to talk about introduction, about carotid artery stenosis and treatment, diagnostic strategy, what are the treatment options, CA versus CAS guidelines, our own experience, and hopefully by the end of this session, I could answer, we know that when to refer for CAA or CAS. I mean, if you miss this talk, you can just get it online at DocQuity. I think this, the voiceover session or recording is on the DocQuity apps, because I did this talk for the Malaysian Stroke virtual conference. Anyway, a bit about history of carotid stenosis. Okay, back in 100 AD, it was first described by Rufus of Ephesus. He mentioned about carotid artery, and then subsequently Hippocrates mentioned the first ischemic stroke, and then Cherry mentioned as atherosclerotic plaque in ICA causing the stroke. And the father of modern vascular surgery, Michael DeBakey, back in 1950s, he actually performed the first carotid endarterectomy. And subsequently, he was also the first person to perform eversion and arterectomy in 1959. How about carotid artery stenting? This person, Klaus Matthias, in 1977 performed the first ICA angioplasty, and then after that, he performed stenting as a bailout because there was an intimal flap following the ICA angioplasty. Okay. Just a definition of stroke. I think we all know that stroke is a clinical syndrome and it lasts more than 24 hours. Okay, TIA is the one that we should also recognize, which is a bit more subtle, the symptoms or syndrome. It occurs less than 24 hours. So this kind of group that we would like to tackle actually, because most of them actually doesn't have any permanent neurological deficit. For epidemiology, it's quite common, about 1 in 100,000, or the stroke rate is actually about 200 over per 100 population, 100,000 population per annum suffer from stroke, and majority of them actually ischemic in nature, about 80%, and about 50% actually account for, caused by carotid artery stenosis. So that's how common it is. Unfortunately, we don't see it that commonly here. I'm not sure why. Anyway, it's the third most common cause of death worldwide. How about in Malaysia? This data is taken from the stroke registry back in 2016. I think our data are actually more or less the same. As you can see, ischemic stroke account for about 80% of the whole stroke population, and then about 40% actually account from the large vessel problem, which is the MCA and also the ICA. And the top 5 cause of mortality in Malaysia, cerebral vascular disease is number 5. And how about post-stroke death? So as you can see here, about quarter of them actually caused by massive infarct. And then for disability, I think, as you can see from the modified Rankin scale, more than half of these patients actually have permanent disability where they are actually dependent. So what is the cause of stroke? As I mentioned before, most of them are ischemic in nature, and about 75% is actually from the carotid artery territory. As you can see here, either the ICA or the MCA. And this is just a pathological process of atherosclerosis. So why is it important? It's not just about the narrowing of the blood vessel. As you can see here, you see sometimes the atherosclerotic plaque has ulcerated, has this element of plaque where it's protruding out into the vessel, which over time can actually dislodge and cause ischemic stroke. So that's how dangerous it is. So this is just for medical student. So basically in the history taking, you should ask all the symptoms, TIA, stroke symptom, and for those physician we need or surgeon, we need to see whether this patient having crescendo or stroke in evolution, because this kind of patient actually quite sensitive to develop a major stroke in the near future. And also we can ask them about eye symptom, which is the amaurosis fulgax, and also don't forget the cardiovascular risk factor. And in the physical examination, apart from checking the neurological status, we can also check for carotid brie. We can actually about 60% sensitive and specific. Okay, so for the stroke risk factor, you can stratify it either non-modifiable or modifiable. As you can see, non-modifiable, basically nothing that we can do about it. But for the modifiable, I think what we can do is we can control the blood pressure, smoking cessation. Okay, you can refer to Prof. Amir, diabetes mellitus, AF. All these things you can actually control them in order to reduce the patient risk to develop stroke. And this is just data I took from the GBS 1996. As you can see, from the life table analysis, the survival of stroke patient actually rapidly reduced over, this is just a 36 month or 1.5 year. As you can see, crescendo TIA or progressive stroke, they tend to die over time if we don't tackle them, somewhere here. So how do diagnose these patients? Okay, so I think the first line is still carotid duplex. I would like to emphasize that these investigation need to be performed by experienced operators. They need to be trained, or else you won't get a proper, proper calculation of stenosis, proper criteria or proper imaging that we wanted to diagnose the severity of carotid stenosis. And experienced operators can actually diagnose unstable plaque, which will guide us for the treatment itself. And then if we still think that it's not enough, we can supplement this investigation by doing a CT angiography or MRA or diagnostic digital subtraction imaging, as well as transcranial Doppler to look for any hits. But having said all these things, I've worked in a center before where we will just use carotid duplex for us to diagnose it and then to proceed with the operation. So because all these things like CTA, MRA, they actually cost a bit, and also they will delay the process. Because for example, in where I worked before in NHS, we have a guideline where we have to do the carotid intervention, either operation or stenting, within 2 weeks. So this is how we evaluate the carotid stenosis. As you can see, the method used, either NSAT or ECST. I am quite comfortable in using ECST because we tend to evaluate it based on the true diameter of the internal carotid compared to NSAID where actually diameter based on the distal carotid artery. And you can see here, based on the percentage of stenosis, you can get a very high peak systolic velocity, right? This is just some of the recommendation. As you can see, this is taken from the latest ESBS guideline. So duplex ultrasound is still the best first line investigation, is graded as level 1A. Okay, all right, a bit about asymptomatic carotid stenosis. So doesn't really matter whether you are, from the ECSE or EST, but both of them actually show that if it's more than 70 or 80% stenosis, the freedom from ipsilateral stroke is quite low. As you can see, they tend to develop stroke over a period of 18 months. And as you can see, the stroke rate from those two large trials, so 13.1% will develop major stroke at 2 years, and about 13% develop stroke, any ipsilateral stroke in that year. And from the ECST, it increased to about 16.2% to develop stroke within 3 years. Okay, but most of the stroke actually occur within the first year of the event. For asymptomatic, it's slightly different. As you can see, the one that develop stroke is actually more than 75% stenosis, where the stroke rate is about 3.3%, not that high. Even less than 75%, the stroke rate even lower, only about 1%. So that's why at the moment now, we don't really recommend intervention for asymptomatic disease. This is same thing that I mentioned before. So no increase in stroke with increase in stenosis, except for more than 75% to 99%, where it actually double. So in UMMC, we do work as a team, me, Prof. Khairul from IR, Dr. Fadli, and also the neurologist, Prof. K.S. Tan. A lot of people actually on board, neurosurgeons, so we do our regular MDT. I mean, if there's a carotid stenosis patient, normally we will discuss them on our Monday morning meeting. And then from there, we will decide whether is it really beneficial for the patient to actually undergone carotid artery endarterectomy or stenting. I mean, before we embark on this procedure or operation, patient need to be optimized. Medical therapy should be enforced. I mean, smoking cessation, exercise, like what Prof. Khairul did, antiplatelets, statins, all these things need to be started. And then there's also a target level where I don't think I need to delve on this thing too much. Okay, so these are just a guideline. Also the guideline from the, from the society. So you can just get it online. But most of them are level A. Okay, so now back to the carotid endarterectomy. Okay, so this can be done either by both GA or LA. I mean, according to the biggest trial, the GALA trial, I mean, there's no difference between the two. So you can, you can perform it whichever that, way that you want. For me, I would like to do almost all my patients under general anesthesia, and then I normally do it with a shunt, okay, and also a patch rather than primary closure. And we normally monitor our patient intraoperatively with cerebral oximeter, and I know some centers actually do TCD. And of course, after this kind of surgery, you should monitor them in ICU setup. Just some diagram of how we do an endarterectomy. Okay, so on the left is the standard CEA, where we open up the vessel, and then longitudinal arteriotomy, we remove the plaque, and then we suture it close. Normally I put a patch. Eversion and endarterectomy is slightly different. This can be performed by a high volume center, where we actually disconnect the ICA from the carotid, main carotid, and then evert it and remove the plaque, and then re-implant it back. So if it's done properly, it can be actually be faster than the standard CEA. This just some of the picture from the recent operation that I did. I think this was about 2 weeks ago. We did about 2 cases for the past 2 weeks. So standard anterior to the sternocleidomastoid incision, and then we use, this is the shunt, Pruitt shunt, and then this is a cerebral oximeter that we use, and also that's the patch. I will use a bovine pericardial patch. So we open up, expose the carotid vessel. As you can see, proximal control, common carotid, distal control, internal and external. And then after that, we open up, we clamp, open up, give the heparin, put in the shunt, and then make sure the blood perfusion to the brain is restored. And then after that, we remove the plaque. As you can see, that's the KFCs, McD's, Texas chicken that contain in the cholesterol plaque. So as you can see here, all right, so that's removed, and then after that, we just patch it, and then they become big again, and the rate of restenosis is quite low. So as this picture mentioned, better in than out. Something particularly important in this slide, as you can see on the right hand side of the picture, those are the ulcerated plaque, which is very dangerous, and some of this plaque can actually rupture and then dislodge in the brain. It can cause ischemic stroke. So definitely better in than out, okay? So carotid endarterectomy doesn't happen without its own complication. Bear in mind the complication is not that high. As you can see, cardiac complication is there, about 1%, cranial nerve injury also there, about 5 to 20%, but most of them are temporary, okay? A lot of, about less than 1% is actually permanent, okay? So you need the post-op ICU monitoring because of this, hemodynamic instability because of the carotid dysfunction. It can sometimes happen. Cerebral hypoperfusion syndrome, and also recurrent stenosis, which very rare with, with a patch closure. Okay, wound infection and bleeding is almost never happen. Okay, so moving on to carotid angioplasty or stenting. This is just a procedure where we place the stent or stent graft to cover the atherosclerotic plaque, as mentioned in this picture. It's not like peripheral stenting where you can just put the stent there. So one thing in particular is when we deploy the stent, some of the atheromatous plaque can actually dislodge and then go to the brain, causing stroke. So in this particular procedure, you need embolic protection device, which is this one. Okay, bear in mind that there will be a cost issue because most of this procedure is quite expensive. Standard probably about 15-20K if done here in UMMC. So there is advantages and disadvantages. So advantages of CAS, basically we can use it in the patient which very high operating risk because it doesn't normally require general anesthesia. And then if the patient had previous carotid stenosis before, so it can be invaluable where you don't want to reoperate on this patient because risk of cranial nerve and everything is quite high. However, bear in mind that carotid artery stenting has a higher risk of intraoperative stroke compared to open surgery because of the problem with free-floating thrombus and antiplatelet issues and etc. Okay, this is one of the, I think this was done back in 2019. I normally do this procedure with Prof. Khairul. So as you can see here, this patient have, what they call that, bilateral carotid stenting done in other center, and he only developed quite significant carotid stenosis in the stent, also distally. So what we did was we just stent the whole area with the help of this embolectomy protection device. Okay, so those kind of things can be done. Okay, moving on to the guidelines. This is basically my favorite guidelines, quite recent, European Journal of Vascular Surgery in 2018. So that's the latest one. And also my practice is basically also based on the CPG, Malaysian CPG as well. This is 2012. Okay, this taken from the ESBS guideline. Okay, they based on the symptom of stroke or TIA within the 6 months. So anything less than 6 months is considered as symptomatic. More than 6 months is considered as asymptomatic. As you can see for the symptomatic on the right hand side. So standard imaging, of course, your duplex ultrasound. Okay, as you can see, the carotid stenosis, anything more than 50%, it's recommended to do carotid artery endarterectomy or stenting, and anything below that should manage medically. All right. Whereas if you have an asymptomatic patient with carotid stenosis, so anything more than 60%, so there is also a caveat here where the life expectancy is more than 5 years, favorable anatomy, and then more than one feature suggesting higher stroke risk or on BMT, yes, you can actually recommend them for surgery or stenting. Okay, because as I mentioned before, the risk of stroke in patient, asymptomatic patient is relatively quite low. So just a CA versus BMT outcome. As you can see, CA trim the BMT in a patient with more than 70% or more than 50% stenosis. Okay, so you get quite a high absolute risk reduction there, and also the CA versus CS outcome. As you can see here, the stroke rate of CA is much lower compared to CAS. However, the death rate is slightly higher, as you can see here. So the guideline actually favor CEA. As you can see, in the stroke endpoint is actually better in the CEA group compared to CAS group. Having said that, the advantage of doing CAS is actually you can avoid cranial nerve palsy. The same thing that I mentioned is just a guideline for the carotid endarterectomy. As you can see, the level of evidence quite good. Is level 1A. Okay, so moving on, how about in Malaysia setting? Okay, what does the CPG, our CPG mention? As you can see, more or less they taken the, they do the guideline based on the NASET and the ECSC trial. As you can see, they also recommend that carotid stenosis should be treated in a patient with more than 70% or more than 50%. The level of evidence is quite good. Having said that, as you can see, the one that actually caused, people not to refer is because of this. It should be done in the center where you can achieve complication rate of less than 6%. So I'm not sure whether there's any one of the vascular surgeon or neurosurgeon here have done 100 cases in Malaysia. So how can you expect for you to have a 6% rate? So I'm not sure, but I've done probably more than about 40 cases, since I was trainee, and I can tell you that it's going to be very difficult if we don't get referral to achieve our numbers. Even though that the guideline actually said that it's level 1A. Okay, so at the moment now, I just do symptomatic patient. Asymptomatic, the recommendation even more stringent. As you can see, they only recommend in a high grade symptomatic asymptomatic carotid stenosis more than 70% in the center or surgeon with less than 3% morbidity or mortality risk. Okay, so that's the truth. It's similar to for carotid artery stenting. Okay. Special consideration in patient with combined carotid and coronary artery disease. I think normally I get this kind of patient from my cardiothoracic colleague, where they mainly do screening for patient who will undergo coronary bypass. So as you can see here, there's a lot of things been done for for this kind of patient, where we can do stage procedure, we can do synchronous or same day. So most of these patients actually asymptomatic. So documented 30-day death or stroke rate is about 7 to 8%. So it's actually quite high in a patient with more than 60% stenosis, and also have a same contralateral occlusion. So Jessica, I'm not going to go through this. Okay, so how do we decide which patient go for which? I mean, this is for those who have coronary artery disease as well. So if the patient having symptomatic carotid stenosis and already decided for elective CABG, so you can actually, I mean, it's recommended to actually proceed with the CEA or do it concurrently with the CABG. Okay, for asymptomatic patient with high-grade stenosis, so you can do the CEA or CES after the CABG. If the patient having bilateral high-grade stenosis, then you should do a CEA or CAS pre or concurrent with the CABG. If the patient has symptomatic carotid stenosis with a patent drug-eluting coronary stent within a year, then it's recommended to do a CAS. Because why? This patient, most of them have dual antiplatelet therapy for the drug-eluting stent. So it's better to do stenting rather than open surgery because the risk of bleeding. So this is just our experience. As you all see, I've restarted the unit back in 2017, and we do our MDTs. And sad to say that our numbers is still quite low. So these are our numbers. We only have done 11 cases for the past 3 years, and this is the highest volume in Malaysia. So that's how sad it is.